Dr. Virani, I'm incredibly excited to be here talking to you today about a topic that's very important and exciting for us. We've both done a lot of work in this space, so I'm really looking forward to this discussion, and I really appreciate your willingness to collaborate on a paper with us at the THI Journal on this incredibly important topic of SGLT2 inhibitors. Before we begin, I just wanted to talk to everyone out there about the history of SGLT2 inhibitors, how they're kind of rooted in serendipity is the best way I've heard describing it. Where it started was this initiative by the FDA where there was some concern from a certain class of medicines in the diabetes space where there was an increased risk of cardiovascular disease. So the FDA made this initiative that all diabetes medicines in the future must be evaluated for cardiovascular outcomes. And what that did was allow this explosion of cardiovascular research and these new medicines that we would have not have otherwise prescribed or known about for cardiovascular benefits, one of which are SGLT2 inhibitors that have had immense benefits in the cardiovascular space. So that said, cardiologists have had some reluctance in prescribing SGLT2 inhibitors that were typically seen as diabetes medicines. Why would a cardiologist prescribe an SGLT2 inhibitor?
Yeah. So Matt, first of all, congratulations on the publication of this very, I would say, good review. That's very easy to follow. So I would encourage all of our listeners and viewers to basically go read this article, which is very easy, and the summary there is excellent. I think like with any other therapy, like we all are bound by clinical inertia, therapeutic inertia. Any way you say it, we all have habits of, when we were trained, and you're, of course, still finishing your training. So the therapies that we use when we were doing our training, those are the therapies that stick with us. And then it's very difficult to make that switch. So that's one aspect of it, that we all have habits, and it's very difficult to change those habits. Now, in the case of this particular class of medications, SGLT2 inhibitors, traditionally the paradigm has been that if I am a cardiologist, I'm not going to do anything with medications related to diabetes. And partly it was because of what you mentioned. We just did not have therapies that improved cardiovascular outcomes. We were mostly looking at therapies that would not hurt the patient from a cardiovascular standpoint. So the thinking was, well, let me leave it up to the experts who are managing diabetes and just focus on cardiovascular stuff with risk prevention that's outside of diabetes. So hypertension, a cardiologist might get into, lipids they would, but when it came to diabetes, we were very hands-off, and we would say that let's have our primary care colleagues or endocrinologists basically manage this. But of course, with what happened with this class and GLP-1 receptor agonists, it's changed now. And actually, if we want to be the folks who are not just treating disease, but we are working on very aggressively risk reduction, both primary and secondary prevention of not just ASCVD, but also heart failure, we really need to get in as cardiologists when it comes to SGLT2 inhibitors.
Fantastic. Just to press you a little bit in the number of medicines that we have for a patient with heart failure, where would you put SGLT2 inhibitors in your prescribing pattern of, do you initiate them first? Do you tend to initiate them after they're on established beta blocker, ACE/ARB, angiotensin receptor antagonist medicines?
I think I am still a little bit traditional in my thinking, so I would usually go with the ACE/ARBs, first, or neprilysin inhibitors, add beta blockers, and then MRAs as well, mineralocorticoid receptor antagonists, and then add this therapy. Now, one thing, of course, that becomes a deterrent sometimes is the dose. You're not able to get to high doses of each of these therapies, but I think I am moving more and more towards where you have a combination therapy where you're working on various axes and then try to get the maximum benefit out of these medications. So that's generally been my approach, but I don't think that that's a universal approach. The other considerations here are that if you are trying to take care of diabetes at the same time, your A1Cs are not too high, but they're in the 7.58% range, then perhaps introducing SGLT2 inhibitor early on might give you more benefits. They, of course, as we will talk about, they also have this natriuretic effect. as well as, diuresis because of glyceria that you get from these medications, then if you have a little bit of volume issue as well, then they might help you acutely with some diuresis as well, which can benefit you. So depending on the patient, but generally I would go with those first 2 or 3 classes and then add this based on the patient. But of course, you don't need to be a diabetic in heart failure now to receive SGLT2 inhibitors.
Absolutely. So I think it's important for the listeners to know that there's SGLT2 inhibitors are indicated both for the treatment of heart failure, but they also have really big benefits for the prevention of heart failure. And that's some of the things that we talked about in this paper of the landscape of trials, especially in the diabetes space. Let's just talk about a couple of them, starting with, EMPA-REG, and further on the Canvas trial, 2 medicines, and there's also Declare-Timi, that were used for the prevention of heart failure in patients with diabetes. Both had very impressive results. These are patients that had pretty high baseline risk for heart failure. They already had established diabetes, and it did show pretty good results, a 59% primary prevention. I think we should also give credit where credit's due. The first author on this paper, Alan Zang, is a fantastic medical student at the Baylor College of Medicine who did a lot of great work to summarize the landscape of evidence out there for cardiologists. But going from EMPA-REG to Canvas and Declare-Timi, both with empagliflozin, canagliflozin, dapagliflozin, all the flozins, with very consistent hazard ratio reductions, which is pretty impressive, going a 35% relative risk reduction for the primary outcomes of hospitalization for heart failure or unstable angina. And then talk a little bit about the patients with established heart failure and those with reduced ejection fraction, less than or equal to 40, that had very similar effect. And I think these trials were DAPA-HF, EMPEROR reduced as well.
Yeah. No, I think some of the observations, and by the way, the table there in this article is an excellent table that I have personally found very useful. So I think that's another reason why our listeners and viewers should go and look at this article. Some observations there for both prevention of heart failure in the earlier trials like EMPA-REG, and then the whole heart failure, number of trials that have opened up, which I think we should talk about in a little bit more detail. A few observations there are that if you look at EMPA-REG, 100% of the patients had established cardiovascular disease, right? And then when you come through other trials, right, that happened there right after that, if you look at Canvas, the numbers come down a little bit. And Declare, you have, I believe, more than half of the patients were high-risk primary prevention patients. But when you look at those hazard ratios, they really do not show any heterogeneity of effect when you look at primary versus secondary prevention patients. So just saying that these are very impressive results and these medications work even in high-risk primary prevention patients, not just our secondary prevention patients. So I think that's one thing for clinicians that would be extremely important as we look at these trials as a continuum. The second observation is that when you look at baseline use of ACE, ARBs, or beta blockers, there again does not seem to be heterogeneity of effect. So whether the patient is on an ACE, ARB, whether they are not, whether they're on a beta blocker or not, they still seem to derive a benefit. And I think we've talked about it before as well. In this day and age, it's become very difficult when you didn't have any heart failure medications and you just used an ACE or ARB. Well, you saw a lot of benefit. Now, we always talk about what if we repeated those trials now with newer therapies? Well, this newer therapy actually did this trial, and there were patients who were on these medications. It does not seem like if somebody is on an ACE or ARB or a beta blocker, that you're going to lose any benefit in terms of prevention of heart failure when it comes to this class of medication. So those were some observations I had, and I'm sure you might have a few others as well.
Yeah, I think that's a very impressive thing to be able to be additive to already established therapy. The other thing that always surprises me about these medicines is that we talk a lot about heart failure with reduced ejection fraction that we typically think of heart failure, but there's a whole separate class of heart failure in the patients that have preserved ejection fraction. Completely different phenotype, very difficult to treat because it is so heterogeneous. And then finally, with a couple trials that we can talk about, EMPEROR preserved and then DELIVER, empagliflozin and dapagliflozin, both finally showing some sort of treatment option for patients with this pretty it can be pretty difficult and a very symptomatic type of disease, both of which reducing the risk for hospitalization for heart failure. I think it's always great when you can keep people out of the hospital with over 30%, nearly 30% relative risk reduction. Talking a little bit about why we think that is, I want to talk a little bit about the mechanisms, if you don't mind.
Yeah.
So we talked a little bit about natriuresis and that being able to just get fluid out of the body, decrease the amount of pressure in the heart, improve preload reduction in a very stressed LV or myocardium. What other types of benefits or mechanistic benefits do we see with the SGLT2 inhibitors?
Yeah, so I think the most important one would be what you're talking about, right? Just that diuresis that you get because of sodium that's lost as well as glucose that's lost in the urine, reducing your preload, reducing your wall stress. And again, this is all very well highlighted in the paper as well. That perhaps is one of the most important mechanisms. And that's what we thought initially was the only thing, but then there is a lot of stuff in terms of how your metabolism switches. Now that you're losing some glucose in the urine, your body pivots, especially your heart pivots from being more dependent on glucose to now being more dependent on fatty acids and ketone bodies. And there's some preliminary data that per molecule of oxygen, you may be able to make more ATPs when your metabolism shifts, right, from glucose to ketone or free fatty acids. So that might be one other mechanism, and I think you wanted to add a few things.
Yeah, the EPO effects I think are fascinating as well. We've done studies in this space looking at mediation analysis. So when you have an outcome, through which pathway do the theoretical benefits exist? And hemoglobin is such a strong mediator of SGLT2 inhibitors. And now that we have some evidence to show that EPO levels rise with SGLT2 inhibitors, increase that oxygen delivery to very needed and important tissue, I think is pretty impressive.
Yeah.
Talk a little bit about the weight reductions, epicardial fat reductions that you get with SGLT2 inhibitors.
Yeah, so I mean, I believe on average it's about 3 kilos you lose, some of which is related to fluid, but perhaps maybe 60-65% of that may be related to actual reduction of body fat and all those things. Which again is important when it comes to heart failure, ASCVD as well, and HFpEF as well. Maybe there is some contribution to that. Epicardial adipose tissue goes down. Now we know that is not inert. It has some paracrine effect whereby it may lead to more inflammation. Now, when all of these things are happening, your systolic blood pressure goes down as well, and I believe the numbers are somewhere around 3.8 millimeters of mercury as an average amount of systolic blood pressure reduction. Now, if you take it out, even at an individual patient level, forget about population level, if you bring blood pressure down by 2-3 millimeters of mercury, it's a lot. But even for a patient, reducing this much systolic blood pressure can have very large effect size in terms of their future risk of heart failure and in actual heart failure management as well. And then, of course, you have some of the other benefits like reducing triglycerides, raising HDL cholesterol. So all of these things combined, I think, it would seem like that the medication has a lot of things beyond just being another diuretic that you might think it might be.
Yes. One of the big questions I've gotten asked is, are SGLT2 inhibitors, do they just act on SGLT2 receptors, or are there pleiotropic effects where they may act outside just that single receptor? And I think that the question or the answer is still out there, but I think that the body of evidence to show that this works on a whole body system, not just the nephron itself, is important.
Yeah. And on the same lines, I think other area that perhaps maybe you want to talk about a little bit, Matt, which is highlighted in the paper very clearly, is we talked about prevention of heart failure. We talked about treatment of heart failure. But one other area where these medications are coming out to be very strong is reduction in progression of CKD.
Yes.
Do you want to talk about that a little bit?
Yes, absolutely. So within the diabetes space specifically, this has also been studied outside diabetes, but focusing what we did in the paper on just the diabetes space, there were 3 very big trials with the same medicines, canagliflozin with Credence, dapagliflozin with DAPA-CKD, and then empagliflozin with EMPA-KIDNEY. In all 3 trials were positive or nearly positive for improvement in CKD progression to ESRD, and then improvement in decline in EGFR, your glomerular filtration rate. So these medicines have really profound effects to prevent the progression of kidney disease. And I think this was one of the first medicines that we had in this space. That's so exciting. People think of kidney disease as this eventual progression to needing dialysis. And for the first time, we can offer this medicine in addition to ACE ARBs that are typically prescribed that can help prevent people from, making it a disease that you have to, what am I trying to say? A disease that you have to live, that you can live with versus a disease you have to suffer from or have your eventual decline in kidney function.
Yeah. No, and I think that to me is a big advantage because, and I know that when you get a cardiac patient and with that you have CKD, it's very, very difficult to manage. That's one area where we definitely need a lot of medications. We have some like ACE ARBs and that whole axis. But in addition, now we have another medication that allows us to prevent that CKD from progressing in these patients, which is actually very common, and the same happens in patients with diabetes as well. That CKD is extremely, extremely common. So the more medications we have that just do not reduce ASCVD and heart failure related outcomes, but also improve CKD related outcomes, I think that it becomes that much more important to use these medications.
For our cardiology audience, one of the questions that we sometimes get is, because SGLT2 inhibitors have this natriuretic effect, what do you do with a patient's diuretic? Are you someone that down titrates their diuretic?
Yeah. I mean, I usually look at two things. One is volume status and one is blood pressure, right? So, and then make the decision. If the patient is already having borderline blood pressure, they're a little bit orthostatic, I mean, the easiest thing to do and the most practical is cut down on the dose of the diuretic, because that's not going to give you a mortality benefit. That's symptomatic for most part, but then you have, you can add a medication that actually gives you that much more benefit with actual hard outcomes. So that's one practical thing that I've done, but then definitely keep a very close eye on the patient's blood pressure, glycemic status, and kidney function. All of those things need to be monitored when you're initially starting out with this medication to make sure, that you're not, the volume, they're not dehydrated, right? If patients become dehydrated, then we know that you can have a lot of problems with this class of medication. Sometimes when patients are on insulin or agents that lead to insulin secretion, it can lead to hypoglycemia. So keeping an eye on that, and again, all of that can be done very easily, and then keeping an eye on the EGFR generally, and then creatinine. It may go down some, but the general recommendation is that as long as it's less than 30%, you can continue the dose. And then I think you, of course, do procedures in EP. I'm sure you get a few patients who come in on SGLT2 inhibitors, their NPO. So what are some practical things that you're doing there to make sure that clinicians can learn from that when it comes to practical use of this medication for patients undergoing procedures?
Absolutely. So a lot of the things that we do pre-procedure are holding SGLT2 inhibitors typically 3 days prior to their procedure. And the reason for that is not so much the diuretic effects or the hypoglycemia, but there's a risk of euglycemic DKA, and it's a rare condition, but it is one that can have some serious consequences where your glucose can look normal, but you still are in this ketoacidotic state that is difficult to recognize and luckily easy to treat with insulin, and you actually can give supplemental glucose as well. But it can be important, especially for our anesthesia colleagues, to not recommend putting patients on a procedure table when they're on SGLT2 inhibitors. Now, emergent cases, we can deal with those consequences. The patient always comes first. What other side effects have you typically seen with SGLT2 inhibitors?
Yeah, so of course they lead to glucose excretion in the urine, so UTIs as well as the genital infections, the risk is high. So you got to be very careful. If you're dealing with a patient who already has a lot of those, or hygiene is not that great, then you want to be careful and just see if this is the right medication for them or not. So that's one aspect of these medications that's important. I think volume depletion is one. That's something that we can always work with, but we got to keep an eye on that. You already talked about the DKA, which is a euglycemic DKA. Not a common side effect, but something that I think we should all keep in mind as we are looking at this medication. And then again, just keeping an eye on the EGFR, keeping an eye on the blood pressure, especially when patients who are on multiple medications for heart failure as well, or blood pressure reduction, just to make sure that we are not causing more harm. But for most part, these are very, very manageable side effects. You just have to keep an eye on the patient and be very mindful of what these medications are actually doing, so you don't cause any harm to the
Absolutely.
patient.
I think it's incredibly important. These medications are really safe for the most part for that benefit that you get, especially cardiovascularly, renally, and just the whole body system. So a lot of the things that you and I have talked about are how do we get SGLT2 inhibitors into the hands of patients and clinicians? What are some of the initiatives that you've seen that have been successful to help prescribe these medicines?
Yeah, and I guess perhaps it would be good for our clinicians to know that these are now class 1 medications when it comes to prevention of heart failure in patients with chronic coronary disease. The last set of guidelines that I was part of, we gave it a class 1 recommendation. In patients with heart failure with reduced ejection fraction, it's a class 1 medication, something that should be used. And then for patients with preserved ejection fraction or mildly reduced ejection fraction, it's a class 2A indication, something that can be considered. So these are pretty strong recommendations for SGLT2 inhibitors. But as we have always seen, right, guidelines do not implement themselves. We can write these guidelines, but it's very difficult for those guidelines sometimes to be implemented in clinical practice. And I believe we're seeing the same thing with SGLT2s, although I hope that what happened with statin therapy, that we still don't have 10 to 20% of the patients in secondary prevention who are not on a statin, and about 40 to 50% who are not on the correct intensity of statin therapy in secondary prevention. I hope that doesn't happen with SGLT2 inhibitors. And I think one thing is about increasing awareness. One thing is about making it easier for clinicians to implement these therapies, by having EHR not work against you, but work with you. And I know you have a very good study that I'll ask you a little bit about if you can tell us what you all did. But then there is this thing about the patient side of things, right? I mean, if we look at a patient who has diabetes today or has ASCVD or has heart failure, they are on a lot of therapies. And these therapies are still not generic for most part. They cost a lot to the patients. So the cost becomes a factor as well. So I think all of those things need to be accounted for, right? But from the system's perspective, the system should help the patient and the clinician. So I wanted to get your thoughts on how EHR can be used to actually assist the clinicians when they are trying to make these decisions and see how these very evidence-based therapies, which are now class 1 or class 2A, depending on the clinical condition, be implemented in clinical practice. So I would love to hear about what you all have done to work on this area.
Absolutely. So I think that the EHR for clinicians can seem a little bit antagonist and doesn't always work with us. And one of the things that clinicians always talk about are EHR alerts and how the alert fatigue is very real. So we wanted to try to evaluate or combat that problem by making very focused EHR alerts. And one of the things that we came up with was for SGLT2 inhibitors specifically, because they are underprescribed, we hypothesized that a risk-based approach for the patient may improve uptake of SGLT2 inhibitors. So in the diabetes space, and some of our prior work developed what's called the WATCH-DM risk score that's now actually in the European guidelines for diabetes and cardiovascular disease as the recommended risk score, and implemented that in the EHR. It's a simple 10-variable risk score that can be automatically calculated based off of age, comorbidities, hypertension, blood pressure, BMI, kidney disease, the creatinine, HDL, and then ECG parameters, QRS duration, that are all easily calculatable automatically in the EHR. And then if a patient had a high WATCH-DM score greater than 12, it would trigger an alert for recommendation of SGLT2 inhibitor. And these are patients with diabetes that would have a reason to be on an SGLT2 inhibitor. And those that didn't have a high WATCH-DM score recommended natriuretic peptide screening. Another one of our studies in the European Journal of Heart Failure showed that patients with low risk natriuretic peptide screening can be useful in that population. When you're already high risk, natriuretic peptide level screening isn't additive when you're already high risk. It's those low modifiable individuals where it can be helpful. And 2 order sets, one if you were high, one if you were low. And what we saw, while SGLT2 inhibitors were still lower than we would like to prescribe, still less than 10%, it still was, compared to 0 in the control arm, a very big benefit or big increase in the SGLT2 prescriptions.
So that's very interesting. We did a similar study, Matt, in the VA healthcare system with statin therapy in secondary prevention, by the way. I mean, again, something that's class 1. And what we found was that number needed to alert. So we had to send 10 alerts to actually have 1 prescription for statin therapy in a patient who was not on it. Now, of course, a lot of that could be because the patient had some statin-associated side effect be the reason, or it could be therapeutic inertia or something else. But we needed to send out a lot of reminders, basically 10 on average, to see 1 patient who was not on statin being prescribed. What kind of qualitative feedback did you receive from the clinicians as to what was useful here, what was not useful here with these alerts?
Yeah, I think some of the feedback that we got was a lot related to cost. Compared to statins, where they're on the $4 generic list, a lot of the pushback we received they're great medicines, but in a tertiary care hospital, underserved population, it's just completely unaffordable for some people. Now, since that trial, since we've closed it, there are more affordable options. One that I recommend for people is Mark Cuban's Cost Plus Drugs. They have Brenzavvy, which is bexagliflozin, and is a less than $50 a month SGLT2 inhibitor. Now, it's not one of the ones that are fully studied in the same population, but it's better than nothing, and I still recommend it. It's still something that we do in our clinical practice for patients that completely can't obtain one of the other 4 medications for diabetes patients. The other thing is, if patients have insurance and it may just be out of cost, the manufacturers themselves do have a lot of supplemental pay programs where they can help afford the medications for people that could have otherwise not afforded them. Otherwise, the study was, in our minds, a success just because we were able to improve the use of SGLT2 inhibitors in patients that would have otherwise not have been prescribed them.
Yeah, and that's great because as somebody who's been involved in the guideline writing process now for good 7 to 8 years, and before that was on the side, and throughout that was on the side of what are the gaps, why do we have those gaps in care. I think understanding things from patient perspective is very, very important. I did want to mention here that at the same time when all this work was happening, American Heart Association actually came up with a presidential advisory on cardiovascular kidney metabolic disease, CKM, that we all call, where now actually there are various stages of CKM that are defined. I don't think we'll be able to get into that today, but I would recommend those who are interested to go and read up on that. There's a new risk calculator called Prevent that provides a 10-year and a 30-year risk of not just atherosclerotic cardiovascular disease outcomes, which is what the current risk equations, PCEs that we all use provide, but also a 10 and 30-year risk of heart failure as well, which we all agree is a very, very important outcome. So just something for our listeners and viewers to consider going and looking up some stuff. And this risk calculator Prevent is available online if one wanted to calculate that risk in a patient with very similar variables as we have in pool cohort risk equations, but it's a more contemporary one. Also includes EGFR as a variable. These are race agnostic. But then again, you can do it even in younger patients as young as 30 years old, whereas for PCEs, we need somebody to be at least 40 years old. So and then there are some variables there related to, diabetes control, urine albumin creatinine ratio, and one of the
determinants of
variables,
health,
which is
absolutely.
exactly SVI, actually SDI in this case, which is available for each zip code. So we can get some incorporation of social determinants of health. Of course, it's not perfect, but it's a start. So I would highly recommend that. One question I wanted to ask you, Matt, before we close it out was, some of the patients might be listening to this or viewing this. What are some of the things that you would tell a patient when they're hearing about this class of medication that we know works? What can they do? How can they be an informed patient while having those discussions with clinicians?
Yeah, I think it's a great question, and I always appreciate the patients that have, based off their own personal situation, proposed medicines. And I am always a fan of medicines that can do lots of different things versus prescribing one medicine for lots of different areas. And I think SGLT2 inhibitors kind of are the kind of the preeminent medication for doing lots of different things within the body. I mean, we've talked so much about the metabolic effects, the weight loss effects, the blood pressure effects, and not just to mention the kidney effects and the heart failure effects and controlling diabetes. It's such a jackknife of all medicines. So if you're someone that has diabetes, then I would definitely propose be on SGLT2 inhibitor. If you have heart failure or you're at risk for heart failure, we call the stage B type heart failure, talk to your doctor about being on an SGLT2 inhibitor. They're very easy to take. I think patients like that they're once-a-day medicines that are, we talked about, very low side effects, that potentially you can down-titrate some of your other medicines. And if you don't have heart failure and have other reasons to be on them, sometimes we can cut back on some of your blood pressure medicine or cut back on some of your diuretic medicines, so you're not needing to take as much medicine per day, which is always good news for a lot of patients when we say you can come down on some of the medicines.
Good. And I guess towards the end, perhaps a few thoughts on, what are the unmet needs or research gaps in this area? What do we not know about SGLT2s, or what do you think is going to happen in this area in the next 3-4 years? Because the science is evolving very quickly. So what are some areas where you think this field is moving, or some things we don't know that we'd like to know more about? What are your thoughts on those?
Absolutely. I think the combination of these medicines with other new upcoming medicines are the most exciting to me. SGLT2 inhibitors with GLP-1 agonists, I think, will be incredible. Also things like non-mineralocorticoid steroid receptor antagonists, medicines like finerenone, the medicines for treatment of the CKM syndrome that is going to be so prevalent, and we're learning more about it from the work that you guys have done at AHA to make this a real initiative. And when you have these three medicines that have individually shown to target a part of CKM syndrome, I can only imagine that just like we have the 4 pillars of heart failure, potentially the 3 pillars of CKM syndrome, if not more, for treating this really unmet need of disease that's out there. You had talked about decreasing diuretics. I think it's also worth mentioning the patients that have diabetes that are on insulin. Sometimes because these medicines can cause a little bit of hypoglycemia, sometimes people down titrate their insulin requirements. So being very in tune with your body, being able to check your blood sugars is important. And if you notice that you are having low blood sugars, decreasing your dose of insulin can also be really helpful and beneficial.
Great.
So there really isn't guidelines on combination SGLT2 and GLP-1. I mean, they're theoretically safe to take together, but there's no real guideline on this.
No, we have observational data, as you've seen, where they do work synergistically, but we don't have currently any guidelines recommending they both be used concurrently. But I would just use the word yet, because that might happen very soon, where guidelines might make a recommendation that these two could be used simultaneously. So,
Dr. Virani, it's always a pleasure to talk with you. I always appreciate the amount of work that you've done in this space. You're truly an expert in this field and really a great person to look up to and a mentor. So thank you for being a part of this paper and talking with us today, and I look forward to working with you again.
Thank you, Matt. It was a pleasure being on this paper and a pleasure to do this with you.
Excellent.
Join us again for The Point to learn more from the Texas Heart Institute Fellows and faculty about clinical research and the emergent developments and innovations in patient care. You can find the link for the full THI journal article in the description.